Hi, I'm Dr. Erik Dutson at UCLA, Ronald Reagan Medical Center. I work currently as a surgical director for UCLA Center for Obesity and Metabolic Health. So bariatric surgery in general has been shown to be very effective in the treatment of comorbid factors such as diabetes, hypertension, hyperlipidemia, and the other components of the so-called metabolic syndrome. In terms of the efficacy in treating each of these diseases, we see a preponderance of effect in operations such as gastric bypass and sleeve gastrectomy, whereas the lap band system, which does result in improvements in metabolic syndrome, only does so after significant weight loss has been achieved. So the rapidity of remission of diabetes after gastric bypass and sleeve gastrectomy has not been well understood, but it's been observed since the 1950s. We haven't understood the mechanism, but there's been a recent study that came out last spring that indicated perhaps it's the dietary alterations that post-surgical patients have after these two surgeries that may cause a temporary and immediate remission, which is then backed up by metabolic changes that happen due to the anatomic alterations several weeks later. The three main types of operations that are performed in 2014 for morbid obesity include the lap band system, which is a restrictive procedure, sleeve gastrectomy, which is a newer single-stage operation, and bypass or so-called malabsorption operations such as the Roux-en-Y gastric bypass, or a more extreme form of that, the duodenal switch. So the sleeve gastrectomy was recently approved by Medicare, and that's resulted in a pretty dramatic shift in it as a choice for bariatric surgery for patients considering surgical options. Medicare covers Roux-en-Y gastric bypass, sleeve gastrectomy, and lap band at this time. The caveat with sleeve gastrectomy is it's left up to the regional management teams to approve or disapprove those operations. I actually don't know if duodenal switch is covered by Medicare. At UCLA, we have not chosen to do lap band procedures due to the relative inefficacy compared to the other surgical options that are available. We know, looking at all of the various studies that have been performed over the years, that the performance rate in terms of total weight loss and the longevity of the lap band is very poor compared to the alternatives. And my feeling and our feeling at UCLA has been that if we're going to subject patients to the risk of surgery, that we ought to ethically offer them the procedure that's most likely to work for them. So when we're trying to discuss why lap band is a less effective procedure, a less effective option than the other surgical options, I think primarily the reason for that is the lack of alteration of what we know as enteral hormonal changes. This means basically that when the lap band is placed, it's merely restricting the food intake, and it's not changing any of the signaling, the hormonal signaling that happens when human beings eat food. Other problems that are unique to the lap band system are because it's a piece of plastic hardware that's within the patient's abdominal cavity, include things like erosion into the stomach itself or erosion into the esophagus. I've actually had to carve these things out of people's livers when they erode into adjacent tissues such as the liver. These complications are admittedly rare, but when they do happen, they have a pretty devastating effect on the patients. So when I'm counseling my patients about which of the two main surgical options we have at UCLA, whether it's Roux-en-Y gastric bypass or vertical sleeve gastrectomy, the things that I consider are the efficacy. We know that in terms of resolution of metabolic disease, the efficacy for patients who are up to super obese is fairly similar. We know also that when patients get above the super obese limit, which is about a BMI of 50, that Roux-en-Y gastric bypass in those patients has been shown to be slightly more effective in terms of global weight loss. And for that reason, barring any contraindications for a Roux-en-Y gastric bypass, I will tend to advise my patients that that's probably a better choice for them. So one of the reasons to not do gastric bypass in patients who are otherwise do well with both operations is that there are a somewhat short list of things that can go wrong with the gastric bypass over time. The big thing we worry about is internal hernias. This can be a devastating problem for patients many years after they've had their gastric bypass. Things that happen more commonly are things such as marginal ulcers, which is a development of an ulcer at the staple line connection between the proximal pouch and the jejunum, because the jejunum, the mucosa in the jejunum is not used to seeing the acid from the stomach. And some patients have parietal cells high in their pouch, which cause acid secretion even in that anatomical location, which is less common than other patients. This can be an enduring and lifetime problem for patients if they have gastric bypass versus sleeve gastrectomy. Additionally, one of the things that we always counsel patients on is the likelihood that they may develop iron deficiency or B vitamin deficiencies if they are not supplementing on a regular basis. Calcium deficiencies are also seen as well because the primary area of calcium absorption is in the duodenum. So in patients where that part of their anatomy has been bypassed, the absorption gets altered and they have to supplement for lifetime. So there have been there's been a myriad of devices that have come out related to weight loss surgery that are endoscopically deployed. They are of unproven efficacy thus far. One of the devices is called an endo sleeve, and it's meant to replicate the duodenal exclusion that we see with a gastric bypass or a duodenal switch. This device had some promise in regards to resolution of diabetes because the alteration of the hormones by food not contacting the duodenum. One of the problems with it so far has been a patient's inability to tolerate it because, again, it's a prosthetic device that's employed internally, and patients don't tend to react well to those. There's another device that is being marketed right now that has sort of a dumbbell weight on the end of it, and what it does is acts as sort of a space-occupying lesion within the stomach, if you will. And what that means is essentially the patients may, after eating a significantly smaller volume, feel the same satiety or hunger satisfaction that they would if they had eaten a much larger meal. This is still in the trial state, and we don't know how well it would be tolerated, and it's based on prior efforts with devices called intergastric balloons, which are meant to do the same thing, but for various reasons were not well tolerated either. So these things are all out there, they're being trialed, but so far there's no clear winner in terms of something that might replace Roux-en-Y gastric bypass and sleeve gastrectomy as gold standard therapies. So the prospect and potential of electric pacemakers altering the sense of satiety or hunger was very encouraging in the early results. The randomized controlled trials that have been performed with these devices unfortunately did not demonstrate the effects that we were hoping for, and really there was really not too much difference in terms of people's weight loss between the control settings and the experimental settings. The devices, turns out, work very well for people with chronic nausea, chronic pathologic nausea, but they're not especially helpful for weight loss. And part of the reason for that is we don't really know what's being stimulated when these electrical currents are put into the local tissue. If we knew what the neuroanatomic cables were, we might be able to stimulate them in a way that was specific enough to alter people's sense of fullness or their sense of hunger. We don't know that yet.